Afternoon, people. It is just a minute after 12, so I'll say afternoon. I think we can just give it a few more minutes before we start, and we just let more people join in our webinar. So just a few minutes before we will start officially. Afternoon, everyone. It is 2 minutes past 12, and welcome to our second installment of the TB Think Tank webinar. These take place every month on the third Monday of the month. And for this session, we have the TB Mate project, which is titled The Use of Medication Monitors and a Differentiated Care Approach to Improve TB Adherence. And just a reminder that if you would like to present on this platform in the coming months, please do send your request to my email address, which is ngosi@tbthinktank.org. And as well as we are hoping to hear from the TB Sequel team in the coming month of June. And with that, I'd like to hand over to my colleague, Jody, so that she may do the introductions of our presenters for today.
Good afternoon, everyone. We're really happy to have you all here for our second official webinar of the TB Think Tank. Dr. Nouria Maraba is currently a scientist at the Orem Institute and has been involved in TB-HIV implementation research for over 10 years. She has experience in the implementation of TB-HIV studies in the mines, communities, and primary healthcare facilities. Prof. Charlambus is a South African-trained medical doctor with a PhD who's been involved in TB and HIV implementation science research since 1998 and has published in many areas of TB-HIV research, including TB case finding, TB-HIV integration, and HIV program management. She's provided technical support to the TB Monitoring and Evaluation Unit at the South African National Department of Health and previously served as the head of the Secretariat for our own TB think tank. Rachel Mukura, who's going to round us off, is a health economist working within the Implementation Research Division at Orem, where she conducts economic evaluations alongside randomized control trials. She is currently pursuing her PhD in public health at Wits University. Her PhD is nested within the TB Mate trial, and we'll hear more about that today. So without further ado, Nouria, if you could please take it away.
Thank you, Jody. Good afternoon, everyone. As Jody mentioned, I'm Nouria Maraba, and I will be taking you through our presentation with Salome Charalambas and Rachel Mukura on behalf of our investigators. So TB Major stands for TB Monitoring Adherence and Treatment Outcomes, and this is the use of medication monitors and differentiated care approach to improve TB adherence. And the study was done in collaboration with Desmond Tutu Health Foundation, London School of Hygiene, and IRD. We just want to acknowledge our funders, the city of all the municipalities where the studies took place in, all our participants and clinic staff, and also the research team, the Department of Health as well. So as part of our background, challenges of implementing traditional directly observed therapy have been well documented, and the WHO had recommended the use of digital adherence technologies, such as the EviMed device, which is also referred to as a medication monitor, to assist patient-centered adherence support. There was data from a first China trial looking at effectiveness of using medication monitors, which showed 45% improvement in adherence over the standard of care. Subsequently, the second China trial published recently showed looking at the effect of medication monitors and differentiated care approach on adherence and outcomes showed that those in the intervention arm were 64% less likely to miss more than 20% of doses in a month, but this did not have an effect on the risk of primary outcome. And this was a composite, the primary outcome was a composite of death, loss to follow-up, and recurrence. There's also data that is recently published from Imperial et al. That looked at patient-level pooled analysis of treatment shortening regimens for drug-susceptible pulmonary TB. And this data showed, or the study showed, that those that had adherence of less than 90% were, or had 5%, were at higher risk, or 5% rather, were 5 times at a higher risk of getting unfavorable outcomes. Another study which looked at if bedequiline adherence measured by electronic dose monitoring predicted clinical outcomes showed a strong relationship between adherence and also treatment outcomes. So for our study, we looked at evaluating whether the implementation of the Westpill EviMed device with real-time monitoring and differentiated care approach was able to increase the proportion of patients with greater than 80% adherence to DSTB treatment. And our secondary objectives were to evaluate whether patients who successfully to evaluate patients who successfully completed TB treatment and to measure unfavorable outcomes 18 months post enrollment. Also to explore the feasibility, acceptability, and fidelity, and lastly to evaluate the cost effectiveness of the intervention itself. We used the EviMed device as mentioned, and these are the key features where it generates accurate dosing history. It's powered by a standard disposable battery, which has a 6-month battery life. There's also separate audible and visual reminders of both dosing and refill. And it also has a daily heartbeat confirming operational status in the absence of dosing event. So this was a pragmatic cluster randomized control trial, which took place in 18 primary healthcare clinics in South Africa. In South African 3 provinces, with high number of identified TB cases and with varying prevalence of HIV infection. So we conducted the study in 6 facilities in Ekurhuleni, 6 in City of Cape Town, and 6 in eThekwini. We targeted approximately 2,610 adults and children with DSTB receiving treatment from a local PHC. And our potential participant had to be clinically or microbiologically diagnosed with DSTB, likely to be in an area that we're working in for 18 months, and we're able to attend the 12 and 18-month visit. They had to agree to use the device and be followed up with text messaging, phone calls, and home visits. The differentiated care approach, we provided all our patients with an EviMed device, and those in the intervention arm, we set the device to have audible and visual reminders, and we analyzed our data weekly. If a participant missed a dose, they got automated SMS reminder. If they missed 2 or 3 weekly doses, they got a call from the study staff. Greater than 4 doses, a home visit or clinic visit, and more than 1 week of greater than 4 doses missed, they received motivational counseling. And those in our control arm, the device was set to be in silent mode, and they received counseling as per standard of care. For outcomes, the primary outcome was a proportion with less than 80% TB treatment adherence. And for the secondary outcomes for adherence, we are looking at overall percentage of doses taken and percentage of months in which the patient had adherence of less than 80%. These two I'll talk to, and the rest of the outcomes, such as the successful treatment completion and composite poor outcome measured at 18 months from start. This will be discussed by Salome Charalambas. And for our sample size, we looked at harmonic mean of 145 patients per cluster, and we assumed proportion with less than 80% adherence in the standard of care is 30%, and from that, that would lead us to have a 90% power to detect a 40% reduction in poor adherence. We defined adherence as the days drug intake, total number of days drug intake over the total days. So days drug intake was based on box opening, and we imputed 0 adherence for days up to 186 and 168 after the participant was declared lost to follow up. For our denominator, we defined it as for death transferred out, cured, or completed treatment, minimum of days with a heartbeat from TB treatment start to 168 days, or date of death, transfer out, cured, or completed treatment. For loss to follow up, this was defined as days with a heartbeat from TB treatment start to loss to follow up, plus days from the loss to follow up to 168 days. We excluded patients with no MEM data, and all those who had MEM data, but and also all those who had MEM data but no heartbeat. In terms of our results, we had 18 clusters, 9 in the intervention and 9 in the standard of care. For those in the standard of care, we enrolled 1,350, excluded 17 because of things such as them no longer wishing to participate or having MDR. We were then left with 1,327 for the health outcomes analysis. We further excluded 49 due to lack of adherence data, and this left us with 1,278 participants for the adherence outcome. So for the intervention arm, we enrolled 1,377 and excluded 3.4% because of the reasons listed there, which left us with 1,330 for our analysis, for health outcomes analysis, and also we excluded another 24 to have 1,306 for the adherence outcome. So for our baseline data, we had 2,657 participants enrolled. And in terms of characteristics, our findings, or rather baseline data, was similar except for between the two arms was similar except for differences in province, in TB diagnosis, in ethnic group, marital status, and also HIV status or ART status. And as you can see, our adults or rather participants in the intervention arm were more likely to be HIV negative and bacteriologically positive compared to our standard of care. So just a reminder of how the patient flow is, and just to highlight that I will be talking through the adherence outcome, and just to also indicate that so this is the total population that we will be reporting on the adherence outcome. So for our primary outcome of proportion with less than 80% adherence, we looked at percent of patients with less than 80% adherence. And if you look at the graph on my left, I guess you're right, the circles or the circles in the graph itself indicate the different clinics that were in each of the arm, and already you can see the differences between the two arms. And for the proportion is less than 80% adherence, this was reported to be 48.7% in a standard of care and 18.8% in the intervention arm, and this had a risk ratio of 0.37, and this was statistically significant. We also looked at overall percentage adherence, and we looked at risk difference where we unlocked. We had that's arithmetic mean for each cluster and compared by arm, and the effect estimate here is difference in means. And if just looking at it again, in the standard of care, it's 69.7%, and in our intervention arm is 88.5%. And the mean difference here is 18.8%. And again, this is statistically significant. We also calculated the geometric mean ratio, where we log transformed the geometric mean for each cluster and compared by arm. And the effect estimate here is the geometric mean ratio, which is 1.27. And again, this was statistically significant. We looked at also percentage of months with greater than 20% doses missed. And here we calculated the risk difference, looking at the unlocked arithmetic mean for each cluster and compared by arm. Our effect estimate is the difference in means. And for standard of care, it's shown as 43.0% and 17.5%, and our mean difference was minus 25.4%. And it was also statistically significant. We calculated the geometric mean ratio, where we log transformed the geometric mean for each cluster and compared by arm, and also calculated the geometric mean ratio, which is 0.38 here, and is also statistically significant. So in summary, treatment adherence was improved in the intervention arm compared to a standard of care arm, and treatment outcomes and long-term outcomes were evaluated further. I'll hand over to Professor Salome Charalambos to continue.
Thank you very much, Nuria. So Nuria showed you the primary outcome, which was the adherence outcome of looking at more than 80% adherence to drug-sensitive TB treatment. And I'm going to be looking at the two secondary objectives. The first one, to evaluate patients who successfully complete drug-sensitive TB treatment. And then, because we also did a follow-up after treatment, to look at overall unfavorable outcomes, including 18 months post-enrollment, to see whether people had actually recurrences. So next slide, please, Nuria. Okay, so one of the secondary outcomes was poor end of treatment outcome. So that is now at the 6-month point at the end of treatment. And a poor outcome on treatment was defined as treatment failure, loss to follow-up, death, any treatment restarts, any MDR diagnosis that occurred during treatment, and culture positive at 6 months. We were fortunate to do cultures at the end of 6 months in some patients, although COVID made it quite difficult for all patients to get a culture at the end of 6 months. But those that were found to be culture positive at 6 months were also classified as poor outcome. So therefore, good outcome was anyone who was defined as cure or completed treatment. All the remaining patients were coded as not accessible. So those were the ones that had to transfer out, or where the outcome was not documented at all, where we could not find an outcome. Very few patients fulfilled that criteria. Next slide. So this just, it shows you the summary of what the unfavorable outcomes were. So on the 2,727 participants enrolled, we had 2,070 with defined outcomes, and 432 had unfavorable outcomes. So you can see here the unfavorable outcomes, how they were broken down, and you can see by intervention and standard of care arms. And you can see that we had poor end of treatment outcome in 173 in the standard of care arm and 176 in the intervention arm, and how those are broken down in the different groups. And then after end of treatment, we had people who were culture positive at the end of treatment or restarted treatment, and you can see how they're broken down in the two groups of standard of care and intervention arms as well. Next slide, Nuria. And next. So here we just see a summary of the end of treatment outcomes. So you can see that of the two arms, so 1,259 in the standard of care arm, 1,279 in the intervention arm, we had 172 with a poor end of treatment outcome in the standard of care arm and 176 in the intervention arm. So very similar numbers with a poor outcome at the end of treatment. And that, if you look at it, looking at it by cluster, that's that because it was a cluster randomized trial, it's 14.3% in the mean of clusters versus 13.5%. So again, very similar results. And looking at the statistics, the risk difference was very small, and there was it crossed zero, so that there's not a difference between the two arms. And again, if you look at it in terms of risk ratios, it's 0.82 in the intervention arm versus the standard of care arm, but that crosses 1, so also not statistically significant. So for poor end of treatment outcome, we were not able to show a difference between the two arms. As next slide, Nuria, just to show this. Sorry, just go back, Nuria, to the. So just to show this by clusters. So this is quite different to what Nuria showed with adherence, where there was a clear pattern that the standard of care arm had a worse adherence than the intervention arm. Now, when we look at end of treatment outcomes, you don't see that clear pattern, but you do see that this is kind of, some of this is actually influenced by one outlier clinic that seems to have done worse in the intervention arm than all the other clinics. And unfortunately, that was a clinic where there was a lot of violence taking place in KwaZulu-Natal. So that's one of the features of cluster randomized trials. So our conclusion at the end is that we're not able to show a difference in poor outcome at the end of treatment. Next slide. Thanks, Nuria. So similarly, for the composite unfavorable outcome, this is now looking at an outcome after by 18 months, where it includes all people who also had a relapse. Again, we have the standard of care arm and the intervention arm, and almost the same proportions that had an unfavorable outcome in the standard of care arm compared to the intervention arm. So 22% versus 19.7%. Again, when you're looking at the clusters, you see a slight higher amount in the standard of care arm, but when looking at the statistical analysis, we do not see a difference in the standard of care arm, and especially adjusted for some of the factors that were unbalanced between arms. We do not see a difference in unfavorable outcome at 18 months. So that's within the risk difference and the risk ratios. And now looking at the plots, you see that standard of care arms seem to be quite similar to each other, like all around the same, and the intervention arm is quite varied, in terms of unfavorable outcomes. Next slide, Nuria. So this is just a sensitivity analysis. We had to make decisions about what we would call an unfavorable outcome. And in this sensitivity analysis, we also include any deaths that happened despite treatment success and completing treatment, any deaths that happened after treatment. In the first analysis, these were not included. So you'll see that in the sensitivity analysis, again, the results are quite similar. It's 24% with unfavorable outcomes in the standard of care, 21% in the intervention arm. But looking at the statistics, we aren't able to determine that this is statistically different. And then the plot just similarly shows similar plots. Next slide. This was then now we did a analysis just looking at certain subgroups. And if you see that you're just looking at different groups, for instance, the province, ages, genders, education, and HIV status, you can see that looking at the provinces, the group in the Western Cape do show an improved effect of the group in the intervention arm compared to the control arm, but this is not seen in the Gauteng group or the KZN group. And then another group that also did really well are females. So in females, we're able to see that the intervention improved unfavorable outcomes, but not in men. So these two subgroups just give us a little bit more information about where, maybe the intervention worked better than in other groups. Thank you. Nuria, next slide. So in conclusion, although adherence seems to have improved by the intervention, this did not affect patient outcomes, and we're not sure what the reason for that is. So these are some of the reasons that we're thinking about. So is the adherence data maybe incorrect or inaccurate? That may be a possibility. Some of the data from the previous studies may indicate that adherence should be linked to outcomes. So we're not sure why we didn't see a change in outcomes. Is it that our study population was somewhat less severe disease than in the trials? We have looked at that, at the details of the study populations, and we actually had more HIV patients in our group. We also had people with lower CD4 counts than many of the studies that have been done. So we do not think that our study population had less severe disease than the trials. Is the regimen forgiving? And we're not sure about that, but some of the trial data suggests that that's not true. And then the fourth reason is the outcome that we were looking at in routine drug-sensitive TB programs. And we know that we have moved away from identifying treatment outcomes based on cure, because we have lots of patients who are gene expert positive but smear negative. And so this could be one of the reasons. We know in clinical trials, there are many more cultures done during the entire trial and at the end of treatment. And we only did one culture at the end of treatment. And because of COVID, we didn't get culture on everybody. I think about 40% of patients were able to get culture from. So, so that could be one of the reasons. But, we don't have enough data to actually say what is the main reason. Next slide, Nuria. So in conclusion, there is an indication that the adherence intervention may have improved adherence, but we've not been able to show an effect on treatment outcomes in drug-sensitive TB patients. There is a study called ASCENT, which is taking place at more wide-scale implementation of medication monitors, and it's a larger rollout, and results from that trial are expected soon. But we also think that drug-resistant TB programs may have better documentation of outcomes, and maybe that will give us some evidence if we look at drug-resistant TB programs that have used medication monitors. So just want to conclude. Next slide, please, Nuria, by just thanking everyone who was involved in the study, all the different teams from the 3 different provinces, and scientific advisory committee as well, and all the district health authorities too. Thank you.
Thank you, Nuria and Salome. We'll just wait for Rachel to start her presentation, and then we'll have questions at the end. Thanks so much. Please do type your questions in the chat if you have them in the meantime.
Hi, Judy. Please let me know if you can see my slides.
We can see them. Thank you very much.
Okay. Good afternoon, everyone. So I am Rachel Mukwara, and I'll take you through some of the secondary objectives of the TB MAID trial. And I'll just switch off my camera here to save on bandwidth. Okay. So I'll take you through the qualitative objectives, where the aim was to explore the feasibility and acceptability of implementing WISE-PIL EveryMed device in the differentiated care approach from a stakeholder and patient perspective. So this was a sub-study that was nested within the parent study, and it was cross-sectional in nature. The setting was 3 districts of South Africa. So Ekurhuleni here in Gauteng province, the Cape Town Metro in the Western Cape province, and eThekwini district in KwaZulu-Natal province. For this qualitative study, we selected all 9 intervention sites from the parent study. Sorry. For our methods to do with data collection, our timeline was between June 2020 to February 2021. In the areas that I just mentioned, we conducted our interviews in Zulu, Xhosa, Sepedi, Afrikaans, and English. We had to conduct some of our interviews on Microsoft Teams due to COVID-19. So these are the interviews that had to do with the stakeholders and the staff. However, for our patients, we conducted interviews face-to-face. We used an in-depth interview guide, and we digitally recorded our interviews. Our interviewers were trained research assistants, our Youth Health Africa interns, study coordinators, and myself as a PhD student. Within our sample, we had 6 stakeholders from the Department of Health, from the national, provincial, and district levels. We also had 15 staff members, 7 from the facility and 8 from the research project. And we had 55 patients who we tried to balance by gender and adherence category. Our analysis approach involved thematic analysis, where we followed both deductive and inductive approaches. So our findings were as follows. We found that providers were supportive of the intervention. There was a lot of buy-in from staff who said that they felt involved. They found the intervention easy to learn, and they also felt it was well integrated within the TB program. They felt that they exceeded their facility TB because of the intervention. So one female facility staff member said the following. So this study, it allows us, it does not block us from seeing our patients at all. It allows us to bring them back at any time. And also the dates that they put on the devices, they don't interfere. The second finding was that patients showed a positive attitude towards using the monitor and receiving the differentiated care support. So in particular, patients appreciated the SMS reminders and phone calls, as they felt that the providers cared for their health, allowing them to accept their TB diagnosis better. However, we found that home visits were less acceptable, especially to those who felt stigmatized by their neighbors. Thirdly, we found that the differentiated care approach allows for patient-centered care. So the SMSs, the phone calls, the counseling, and the home visits allowed staff to treat patients as individuals, depending on their situation. Also, there was a close provider-patient engagement, which empowered patients to take charge of their own health. So one study staff member, who's a male, said the following: "I think the differentiated model of care is a very positive thing. It works to an extent because it's not a blanket approach. You don't think of every patient as the same. You sort of attend to each person in their context and try to understand what they're going through." We also found that there were challenges within the intervention and within the adoption system and broad context. So we found there were challenges with the device or the network, which resulted in delays in the system, updating that the device was opened. So some of our staff members said that this created distrust issues between them, the providers, and the patients. There were also some challenges that were experienced within the broader context, especially with those patients who abuse substances. Some providers felt that the device would not work for this group of patients since they lose their devices from time to time. So one study staff said the following: the CCGs, who are the community caregivers, would go on behalf just to find out what's going on, what's the social background of the patient, because we're getting a lot of patients who are addicted to a drug called Iwunga or Nyaope. We also found that there were some perceptions of stigma and fear of disclosure of TB status. And because of these perceptions of stigma, we found that participants would sometimes take their pills out of their devices and leave the device at home when they were outside their household. So the patients made these adaptations to the intervention in order to avoid being stigmatized. There were certain features of the device, such as the alarm and flashing lights, that made it difficult to take treatment discreetly, according to what some of our patients told us. And one study staff member said the following: "So I noticed that it's comfortable for them to use this box when they're at home with the people that actually know what's going on with them. But when they're going to other people that are not aware that they're sick or anything, it seems as if they don't want to carry the boxes." So in conclusion, we found that monitoring TB treatment adherence using the EveryMed Wiseville device and differentiated care approach was both feasible and acceptable to staff, stakeholders, and patients. However, the features of the device that cause stigma would need to be addressed, as they could potentially act as a barrier to scale up. Achieving people-centered TB care, including the introduction of DATs, would require that TB programs incorporate patient insights so as to maximize their adoption and effectiveness. And in order to ensure successful scale-up and sustainability, emphasis should be placed on ensuring that the device and the network operate optimally. Next, I'll take you through the economics objective, which was one of the secondary objectives that Noria mentioned earlier. And here we were trying to evaluate the cost effectiveness of the intervention from a societal perspective. So the societal perspective includes the provider costs, which I'll speak to. And the objective here was to compare the costs of the intervention to the standard of care from a provider perspective. The data collection tool was a time and motion tool that incorporated both observing the TB nurse and the research assistant. We also used timesheets and interviews for some of our staff members who are not clinic-based. We looked at financial data such as salaries and prices of items through our financial records. And to bring all this together, we used the TB Reach costing tool, which we adapted to suit our study. And also just to mention that we did consent our staff, and we did this once off at the start of data collection. And the timeline for this data collection was between June 2019 to March 2020, after which we had to stop because of the lockdown disruption that occurred in March. Our sample size included 2 clinics, 1 intervention and 1 control in each of our 3 regions. And at each clinic, we conducted 10 observations for each of the 6 monthly visits. So what we were actually collecting was the time that staff spent on all activities during the visit. And we also collected resources that were used, such as equipment, supplies, the tests, and the building space, etc. And we also looked at the overhead costs. When we analyzed our data, we excluded time that was spent on any research activities. And then we calculated our unit costs as the cost per patient of using the medication and differentiated care approach. For our sensitivity analysis, we made three main assumptions. The first assumption was that the device would be reused up to 3 times. The second assumption was that adherence monitoring was done by a TB nurse instead of the research assistant as we had it in the trial. And then the third assumption was that the WISE-PIL platform would be used to host all people with TB. And we also modified that to allow for an 85% uptake. For our patient costs, which is also a component of the cost effectiveness analysis, the objective was to look at the costs from a patient perspective. And here we used a questionnaire to conduct the survey. Our questions covered the most recent visits and from the onset of TB symptoms. Our participants' consent was included in the main trial, so there was no separate consent obtained here. And our timeline, so when we actually conducted these surveys, we referred to the month 2 and or rather we conducted this survey at month 2 and the month 6 visit. We used the same clinics as the provider costing, and we targeted 55 participants at each of the same clinics. So the description of the data we collected entailed direct and indirect costs that were related to the patient accessing the intervention. So we had direct medical costs, which is drugs and supplements, etc. We had direct non-medical costs, which included transportation, childcare, phone calls. And we also had indirect costs, also known as opportunity costs, which included days off work, waiting time, personal and household income lost, etc. And all this data was entered onto a REDCap database. For the analysis, we worked out the mean patient costs. We then worked out the unit costs for the patients and combined that with those from the provider costing. Eventually, the plan is to work out the incremental cost effectiveness ratio, which is the difference in costs between the intervention and control sites versus the difference in outcomes in both arms. So this is a table that just shows our incremental costs, which here are shown as cost per patient of using a medication, using the medication monitor and the differentiated care approach. So at the very, just trying to get the pointer here. Okay, so here at the very bottom, you can see the incremental costs range between $37.99 to about $57.52. So that's a difference in costs between both arms. And the reasons for these costs, or the cost drivers, we found were certain items, such as the medication monitors, which you can see here range between 42% of the cost to 64% of the cost. So the bulk of the cost we can see was driven by the medication monitors and the accessories that go with it. Also, another major driver of our costs was the WISE-PIL platform hosting and support reminders. You can see here the range is between 7% and 11% of the cost. Our data management support also was one of the cost drivers, and our differentiated care approach, our home visits, were also quite a large portion of our incremental costs. So when we conducted the sensitivity analysis, where we assumed either device reuse or the alternative CADA or platform hosting, we found that device reuse would lower the incremental cost the most. So our incremental cost now drops between $21.73 to $41.17. So in conclusion, we did see that the total cost range between $64 and $81 in the intervention arm, and between $8 and $39 in the control arm. The incremental cost ranged between $35 and $55. However, the sensitivity analysis showed that when the device is reused 3 times at the intervention clinics, the incremental cost would then drop to between $21 to $41. And further, we found that if we used an estimate of $840 for TB treatment, then it means that the cost of our intervention would only be an additional 5% to the cost of treatment. So that just helps put the cost of our intervention into perspective. I also mentioned that the largest cost drivers were the medication monitors, the data management support, the WiseBill platform hosting, and home visits. And so therefore, one of our recommendations was that we'd need to negotiate a lower cost for monitors with manufacturers. And also before scaling up, we should ensure that devices are at least reused 3 times, as this would help lower the total costs of the intervention. So with this piece of work, the next steps are to calculate the cost effectiveness ratio using the societal costs and also the adherence data. Lastly, I'd just like to acknowledge all our participants, clinic staff, study staff, and all our funders and partners who were involved in this study. Thank you very much.
Thank you very much, Rachel, Noria, and Salome. So we have just over 10 minutes for our Q&A session. And I see we have about 4 to 5 questions, so please keep the questions coming in. So this is for our presenters. So we have a question here that asks, what was the estimated additional per patient cost of using the device?
So Nwazi, I think the first 2 questions have already been answered by Rachel's talk, if that's okay. So that's, I think that was quite in detail. The cost of the device is around $26 and the incremental cost of the whole interventions around $46, and depending on the reuse, as has already been shown. I think that is the I think Farid is asking about per patient costs. I think that's the same as what we have just shown as well. So as Rachel said, that we showing you the provider costs, we also have been trying to figure out patient costs, although they will be included in the cost effectiveness estimates, but they are actually very low.
Okay, we have the other question that asks about, was the p-value not significant or the confidence interval wide?
Yeah, so when you look at that slide with Gauteng, it does go under 1, but the line, the 95% confidence interval crosses the 1. So maybe I can just share it again so the way that the study was powered, the study was powered across the country. It was not really powered to tell the difference per province, but what we did see was that Western Cape was able to show a significant difference in the 2 arms in that province. And in Gauteng, even though there was an improved outcome, it wasn't statistically significant because it crosses the 1. And unfortunately, in KZN, we were not able to show the improved outcome. Nowazi, we can't hear you. I think you're on mute. Sorry.
Apologies. I was just thanking you for your response. And the other question is from Jody asking about the uptake in the trial. How many people declined to participate?
Hi. So I just checked. Yes, we did not present that in the consort diagram. So we actually screened 3,028 and enrolled 2,727. So around 300 people actually declined to participate.
Okay. Were there any reasons given as to why they declined, perhaps? A follow-up question.
So because I have not really looked at the data properly, but generally it's always because of time. But in terms of use of the box, we tried to include that in the consort diagram if like a person refused. But I guess we will look at it further and maybe hopefully include it maybe in the manuscript, because we definitely have not looked at it thoroughly. But it's time, maybe they just did not have time to participate or, sit with the RAs to go through the study. We will look at if the device also had was part of the reason why they did not want to take part in the study.
Okay, thank you for that, Nora. And I think this question is closely linked to the previous question, which asks how many devices were lost during the trial, and were these included in the no adherence data available category?
So in terms of lost devices, we also don't have an exact number because we were sharing, I guess sharing meaning, okay, reusing rather. We were reusing the devices. So we don't have an exact number of those that were lost. And then in terms of, so you said lost and then
and were these included in the no adherence data available category?
No, so what happens with WisePill, or rather with the device itself, is that they are it's able to still upload data even if it's lost, even if the device is lost. So the it being lost would not affect whether we get data for if a person opens them or closes opens the box to take medication or closes it.
All right. Thank you. We have a question here asking, they'd like to find out if there were challenges identified with reusing the pill boxes.
So because we also, as mentioned, we did not buy enough devices to cover all the patients we had to reuse. So I guess we did not have issues with reusing. All you just need to do is we reactivate the device. If a patient finishes the medication up until 6 months, we are able to go back again and purchase maybe data for another 6 months so that another participant can use the device. So we didn't have challenges in reusing the device itself.
Okay, thank you, Noria. We have another question that says, any additional information collected with regards to patient adherence behavior that can be shared, such as demographic factors or geographic characteristics, and the type of caregiver initiating?
Thanks very much, Nowazi. I'm not sure exactly what the question is asking. We have analyzed adherence data and looked at risk factors for poor adherence, and that is currently being put into a manuscript in the control arm, because we were lucky enough that in the control arm we're able to measure adherence with as little interference as possible. In the intervention arm, it will be a mixture of adherence plus people being exposed to the intervention and whether that leads to changes in the way that they behave. So I think in the control arm, we're able to look at adherence and see who is more at risk of poorer adherence, and that has been looked at, and I think the findings have not been surprising. It's the same as before. Women are better adherers, but we will share that, and it is being written up at the moment.
Okay, thank you, Salome. And looking at the time, I think this is one more from Jody, which is, given the lack of effect on TB outcomes combined with some degree of stigma outside the home, would the speakers recommend pursuing the use of these devices at a program level at present?
It's very difficult to answer that one. We're still trying to understand the information. I think we are encouraged by the improved adherence. I think that we have to be aware that we have gaps in our treatment outcome, ascertainment generally. So right now, anybody coming to a clinic for a 6-month visit, we call treatment completion, but we really don't know how adherent they've been. And so we are encouraged by the idea that there seems to be an improvement in adherence. I think we're going to need some corroborating data coming through to fully justify the use of the devices. And what we have seen is very high levels of acceptability, very proportionally low cost, actually, high levels of acceptability amongst healthcare providers as well. So it requires us to keep looking out for this, not saying that we should implement immediately, but that we need to look out and see what other information comes through that either says no, it definitely shouldn't be used, or it should be used.
You're on mute, Leslie.
Maybe I can just ask Rachel to talk to the last question about the treatment. Oh, she's already responded. Thanks, Rachel.
Leslie, we can't hear you.
Thanks, Jody. I was just saying, with 2 minutes left, I think for the benefit of the larger group, I think I can quickly read it out and then she can still respond. So the question asked Rachel, in the concluding slide, she mentioned the treatment cost estimate, which is $840, and this person is asking, is that the inpatient and outpatient treatment cost? Rachel, I know you already responded, but if possible, please, can you respond again for everyone else?
Okay, thanks, Nolwazi. So that's the outpatient DSTB treatment cost for a 6-month period. So these costs are more economic costs and not financial costs. So they would be slightly higher than what you'd expect with financial costs. Thank you.
Thank you so much, Rachel. And I think if none of my colleagues from the Secretariat have any announcement or anything else to say, I think we can round up and wrap up today's session. I'd like to thank our speakers for their time today. I'd like to thank all our attendees for their time as well and for the engagement and the participation. Thank you so much. And without any delay, I think we can close up the session at 1 p.m. It's currently 1 p.m. Thank you so much.
Everyone. Thank you.
Thank you.
Thank you. Bye-bye.
Bye.